Thank you for the invitation to speak at the AWARE lecture for November. It's always my pleasure to address this meeting. Anything I know about bipolar disorder I've learned from people with the condition and their families. Some hard-learned lessons, but there you go. They say they're the best lessons of all. The lecture is very much going to focus on what I believe are the core aspects of bipolar disorder and its management, because it's very easy to get lost in the sea of information about depression and bipolar. And my main focus is really on trying to give a core understanding of the key features that make up this condition. I'm conscious of the fact that many people here this evening will be coming to a lecture like this for the first time. So one of the aspects of trying to understand the prevention and treatment of bipolar disorder will be understanding the condition itself, what it is, what the signs and symptoms are, and what we focus on. Now, on this slide is the core aspect of what bipolar disorder is about. It's a disturbance of the rate of activity of our thinking and our motor function. In the head, going too fast or too slow, or the body going too fast or too slow. It's incidental that the person might feel depressed or agitated or distressed or anxious. You've got to keep your eye on the ball, and the ball in this instance is the process speeded up or is it slowed down? Because that's really the key thing. A lot of other symptoms get spun off from this hyperactive or overactive mind or slowed down mind, and they're important. But the point is you can be quite distracted by anxiety that's driven by an underlying manic episode or hypomanic episode. Manic, the word itself means speed it up. Depression actually means slow down. It exists as a phenomenon of activity, actually, not a mood state in the way we understand it today. In other words, I'm feeling depressed. The use of the word depression in that sense is a relatively new thing in the history of mankind. You go back to the original Greek description of the word depression, it means slow down, and mania means speed it up. So there you go. It's in the words, if we only understood them. So it's being able to see that as the key thing, and that all the other symptoms emerge from that. So here we have a thinking wheel in somebody who is depressed. So it's slowed down, and that's the key thing. And what happens with that slowed down thinking is the person has less to say. There's less thoughts on their mind. They have less thoughts that they can project onto the visual display unit in their mind, such that there's nothing there. There is no future. It's empty, it's bleak, it's blank. And because there's nothing on that visual display unit, there's nothing to pursue in life. And that's where the lack of energy comes from. So energy in that sense is a figment of our imagination. The thinking is also into the past, and it dominates the past. See, normally when we're well, we look in the past in the good old days. Now, and for every era, it's different, the good old days. People look back at less traffic on the road, people more polite, people satisfied with less in life and so on. But there are 1,001 awful other things, like TB being rampant, unemployment being utterly out of control, emigration being a major problem, worse than we've seen in our lifetimes. When people get depressed, the focus on the past is on the negative side of things, and people will often say, well, look, the reason I'm depressed is because of this thing in my childhood. But frequently when that person comes out of depression, it's all gone. They forget about that particular aspect of their past. And it's not just that they're repressing it, it's just not there as a phenomenon annoying the person and upsetting them. So when a person's psychomotor activity is speeded up, the thinking now is thrown into the future. There are 1,001 things up on the visual display unit of a positive nature in the person's mind, and they hop from one grandiose thought to another, often not realizing that that's basically what's happening. Initially, that improves the person's concentration, but as the whizzing in the brain gets worse and worse, the person loses their concentration and has difficulty functioning. They have a great sense of the future, a great energy, reduced need for sleep, and so on. So if we just look at these things in a more ordered way, you will see there's a whole clatter of symptoms of depression. But they all come back to the core thing of how quickly or how slowly the person's rate of thinking is. Because the earliest symptom to occur in depression is generally reduced energy, anxiousness, loss of confidence, and eventually maybe feeling low or down. Then tiredness, flattened, leaden, oversleeping, reduced sleep at night, and sleeping very often by day. The thinking is slowed down, with the result that the person has, as I said, reduced concentration and thinking, a loss of interest in everything, in every phase of the person's life. The person has no value upon themselves, starting with low self-esteem, which gets worse and worse, and may end up in the far end of the extreme where the person feels hopeless, useless, worthless, evil. The person, when depressed, generally will have a tautness or a tightness in their muscles because of the tension in their body. And this causes headache, chest ache, back pain, even bowel disturbance, and so forth, because there almost isn't one part of the body that doesn't have a muscle attached to it. From the heart to the bile duct, to the bile, pancreatic glands, to the middle ear, you name it. And it will often produce a wide array of symptoms that can seem bizarre. I've known plenty of people who, for the first symptom they always got was a headache, for other people a backache, and so forth. And they got to know that in the context of their depression. But could you diagnose depression just on that? No. You've got to go back again to the slowing down of the rate of mental and physical activity. The direct opposite then happens during an elation. The person's mind is speeded up. They feel great. Typical statement, I've never felt better. Free of anxiety, boundless energy, reduced need for sleep, trouble getting to sleep, and this is an important one. Frequently, people overlook this key symptom of a mood disturbance, trouble getting to sleep at night. If somebody is depressed and they've trouble getting to sleep at night, the most important thing to look at there is the trouble getting to sleep at night, because that's directly related, generally, to the mind being too active. Now, I'm not saying people wouldn't have trouble getting to sleep if they were anxious, but you'd have to work out what it is they were anxious about. Were they always anxious? Over the years when they were anxious, did they typically have trouble getting to sleep? So you've got to sort of factor that in. But for most people who are depressed and have trouble getting to sleep at night, their psychomotor phenomenon is overactive. Therefore, you've got to question what's the primary thing there. Is it depression, or is it that the mind is too active and that's the core issue? So the thinking is rapid, the person is over-talkative, their mind is restless. And the final clutter of ones are everything excites the person, everything glistens, sparkles. The person is highly confident, right up to having grandiose delusions. Another key phenomenon is the person is relatively unaware of pain or any physical distress. So somebody with bronchitis or asthma will often behave as if they weren't distressed in that way and injure themselves as a result. In other words, they make their respiratory function suffer even more so. And finally, often the person in these states has a sense that they're going to live forever. So let's now move on and look at some of the subtypes, because these subtypes, these are terms you're going to run across no matter what you read in this area. And it's just to give you a brief understanding of it. So what we're looking at is these subtypes are determined by how frequently and how big the elations are, or the hyperactivity of the mind. Bipolar I, Bipolar II, Bipolar III, and a brief mention of Bipolar IV. Bipolar I is where a person has a big high that lasts months, and in days gone by it would be defined as bad enough to warrant hospitalization. So it's a big high. It's not somebody who's slightly over-talkative and so on. It's quite a significant thing. Now, for many people that is followed after a period of time of days, weeks or months by a low, and they may be then well for weeks to months to years afterwards. As you know, one of the big emphases on treating bipolar disorder is, because it's a recurring condition, prevention becomes a big thing. So if you have a one-off episode of a high, how likely are you to get it again? If it was only a one-off episode, we wouldn't be talking about prevention. The reality of it is that the vast majority of people who have one high have further ones. When I started off in psychiatry, it used to be said it was 50-50. Then it was 60%, 70, 80. Now it's in the 90s. When people do surveys of people who have a one-off high and follow them up over a period of time, the vast majority have recurrences. And that's why the emphasis of the management of bipolar disorder has to be on prevention. Another one is what's called unipolar mania. Unipolar because it's really only got one pole. It has a slight little bit of a dip here, and the person will tell you they feel tired. It doesn't really go on to a full-blown depression, but it's quite mild. Frequently people who get that, they get it at a younger age in life, and if the thing is left untreated and they have recurrences later in life, they have the high, but the bigger lows then begin to become more evident. But it's very important, obviously, that little bit isn't treated with, for example, antidepressants. It's to try and deal with the big high again. Next is Bipolar II. What's the difference between the two, Bipolar I and Bipolar II? In Bipolar II, the person has very mild highs, something that lasts maybe slightly more than 4 days. But it's also accompanied by, or alternates with, periods of depression that by definition have to last 2 weeks. A person's family may be very aware of that, but maybe people at work might say, oh, he's in great form today. So it depends on how well the person is known to you, whether you're going to spot that or not. Now, Bipolar III is where the person has either Bipolar I phenomenon or a Bipolar II phenomenon, more typically, where they're triggered by antidepressants, steroids, ECT, alcohol. So anything that in that way stimulates the high. Bipolar IV is where a person has a recurring depressive illness, very discrete, very definite depressions, often weeks, months, or sometimes years in between the depressions, but they have a family history of bipolar disorder. Why do we put it into the bipolar category? I think it makes sense because frequently the person does have little highs, but they're so slight they get overlooked. But when you get to know the person over a number of years, you can begin to see it. When the family look more carefully at it, they begin to see it. Nothing to write home about those highs, but the point is, what they are indicating is that you need to treat it in the same way with mood stabilizing medication. If you just give antidepressants for that, you'll actually worsen the cyclical phenomenon. Now, next is rapid cycling bipolar II mood disorder. This is where a person has 4 or more cycles of mood in a year. And a cycle is a high and a low, or a high only. Why this emerged as a sort of a subtype is simply this. When researchers in the late 1960s and 1970s began to look at people who didn't respond to lithium in the great way that everyone else did who had bipolar responded to lithium, they found that it was frequently people who had rapid cycling mood disorder that just didn't get stabilized with lithium. Now, it doesn't mean that lithium doesn't work in those instances, but it works much less frequently than it does for people with a recurring bipolar I disorder. So it's a period of high, then followed by a low, a high, followed by a low. And very often, the intervening well periods, here's one over here, are quite short. But there are all sorts of mixtures of it, and there are many different definitions about it, but it's just has to be recognized as a phenomenon that is notoriously more difficult to treat. Not impossible, but more difficult. Because you see, what you'll often find happens initially with people who come along with this problem. They will come typically with a depression. They put on an antidepressant, and they seem to get well with the antidepressant initially, i.e. they've gone a bit high, but nobody still recognizes it as such, and then they flop. And then people say, what happened? What happened at home? What happened at work? In other words, it's only when the mood recurring pattern, the high followed by the low, is followed over weeks to months that it becomes evident that this is a cycle that's determined by internal factors, not external factors. And finally, we come to mixed mood states. Mixed in the sense that there's a mixture of depression and elation or hypomania within them. It's also known as unpleasant highs, or dysphoric, dysphoric means just an unpleasant mood. Phoric is mood. This is not this. Hypomania. Okay. Now, let's look at this a little bit, because a dysphoric hypomania mimics depression, anxiety, agitation, or paranoid ideation, whatever you want. Okay, can mimic anything, but if you keep your eye on the ball and say, is the person's mental state, rate of thinking, more active than is the normal for them? Not higher than average, but what is normal for them. So you've got to find out from the family, what is the normal rate of this person's expressiveness, their daring or harm avoidance or cautiousness, and in that way you get a feel of what's going on. So you look for the key things that indicate this. Now, the problem is that here you've got shared symptoms of, we say, depression and the unpleasant high. They overlap literally 90%. The symptoms that distinguish the dysphoric hypomania from depression are trouble getting to sleep at night, feeling worse in the evening time, agitation or anger, and surprisingly, weepiness. Because typically when people have a depression of bipolar disorder, it's a shutdown state, and people actually often can't cry. And it's often only as they come up out of the depression, they go through a phase of maybe anxiousness, and then you might see a little bit of the weepiness coming through. But do remember, when you go back and look at the original descriptions in the late 1890s, we say to 1920, what you will find is that they used to talk about depressive mania, anxious mania, paranoid mania. In other words, they recognize those as part of that. Frequently, people come along with anxiety where they're very agitated and there's a big chunk of anger and irritability and they have trouble getting to sleep at night. Frequently, that is an unpleasant high masquerading as anxiety. Now, what causes bipolar disorder? Well, what research basically shows is that the key factor is genetic, but on an average basis. So if you take a large group of people, thousands of people who have bipolar disorder, and you work out how much of that has a genetic basis, what you will find is that on average, 70% of it runs in families through many generations, and for the other 30%, therefore, it's got to be environmental. But that average can be made of 10% genetic and a whopping 90% environmental, or 30% genetic, 70% environmental, and so on. Okay, so that for any one individual, what you will find is that if they have multiple people in previous generations who've had recurring depressions or bipolar disorder, it will often take little or no environmental upset or distress in their lives to tip them into overt highs and lows, okay, as a trigger. But then you've other people who have little or no family history of bipolar moods, and it takes enormous catastrophic events in their life, maybe, to trigger their mood upset. So let's look at some of the environmental factors. Well, the first one now is stress. What stress does is, when any of us are put under pressure, is we try harder. That's the first thing we do. When we try harder, if we have no block that stops us only trying so hard, the mood goes high. That's basically where the stress happens. Very often people who come and complain of being depressed, and you say, well, why? What's happening in your life? Why did you get depressed? No, nothing. Everything is going well. Nice, relaxed life. Just this came on me out of the blue. And I was surprised that it happened because 18 months ago I went through an awful time. What were you doing? I was doing this, that, and the other. I was up all night. I was doing... Okay. Yes, they were doing that to deal with a catastrophic situation in their family life or in their business life or both. And that had them in overdrive, and it's followed by the other side of the coin. Okay. So that many depressions that appear to be untriggered by events are in fact the consequences of the mind being overactive for a period of time because of pressure. Steroids, antidepressants, hormones, adrenaline that a dentist might put in a local anesthetic, Parkinsonian drugs, they can all induce highs. You'll get adrenaline-like drugs in, we say, tablets that are used for sinuses, for ear infections, blocked nose and things like that. Alcohol and street drugs generally reduce anxiety and elevate mood. And for people then who are prone to go high, those substances can really inflame the thing. Most people might be a little bit buzzed up over with any of these substances, but the point is, if that person has a tendency to go high, those substances then really put the mind on fire, in a sense. So other environmental factors that we need to be careful of, is jet travel through time zones and changes of seasons. Many people would think that's not terribly relevant, but again, it's relevant to the person whose brain has a tendency towards mood problems. There's no question about that. Often you will find, if you look at admissions to a hospital like this, that the peak months of admissions happen to be from late October into early November. And again, you'll find the same thing in springtime. Anything that disturbs sleep, pain, sunburn, toothache, whatever it may be, is a surefire trigger for putting a person high. If anyone wants to get high, just don't get to sleep for a good while. Okay. Most people eventually switch off and fall asleep, but somebody who is prone to bipolar disorder, it will trigger it. Concussion, multiple sclerosis, brain tumours that affect certain areas of the brain, again, can trigger high. So that, for example, if somebody develops bipolar disorder and there's absolutely, utterly no family history of it, that's one of the things you will think about. Those environmental factors, say, wonder about street drugs, has the person had a bang on the head, getting an MRI scan, all of these things become important in those sort of situations. So let's look at the treatment now. And I'm going to focus initially on the medication end of it, but that's by no means the whole story. In terms of bipolar I disorder, if it's mild, very often lithium can be a very useful agent if it is recurring. One of the things about using something like lithium at an early stage in somebody who's had a high, particularly if they've had a couple of them, is to give it at that point, because what you will find is over a period of 2 to 3 weeks, the person's mood will come down out of that high, and then you realize that the person has had a good response to it. That's the first thing. But that also means generally that that person will do very well on that compound as a preventative agent as the years go by. One of the things about lithium is that once it works, it doesn't unwork. For a first episode, where it's relatively mild, again, something like sodium valproate or Epilim, olanzapine, quetiapine, for quicker anti-manic effect, where it's again used in very minute doses, can quell the problem. For moderate episodes, often lithium with an antipsychotic agent. Now, often what an antipsychotic agent, or which we preferably call an anti-manic agent, these are things such as olanzapine, quetiapine, risperidone, and so forth, amisulpride and sulpride. What they do is they'll often take the top off the high, but there's still a grumbling sort of manic type thinking there happening beneath the medication, whereas lithium sort of quenches it in a much more definite way, and often in a very black and white way, within 2 weeks generally of the person being on an adequate anti-manic dose of lithium. Now, when it's a severe mood disorder, you've got to focus on the mood, sleep and activity needing to be contained by an anti-manic or antipsychotic agent before commencing lithium, because the person may not be eating, they may be totally chaotic, not getting enough fluid, and so forth. So it's not safe using lithium at that point. But generally, after a very short period of time, the person's more overt manic behavior can be helped by an anti-manic agent, and then the lithium can be continued. Now, In treating the depressive side, the trick is or the intention is to lift the mood without triggering another elation. So therefore, you've got to be very gentle with the antidepressants you use. Lamotrigine is very effective, but an extremely gentle antidepressant. Has very few side effects. Carbamazepine, also known as Tegretol, or oxcarbazine, known as Trileptal, low doses can have an antidepressant effect. And when using antidepressants generally in treating somebody in the depressed phase of bipolar I, low doses of antidepressants are best. Now, preventing relapses is where, again, most of the focus for people who have that recurring tendency. Again, lithium is still the treatment of first choice. It works if somebody has a bipolar I pattern of illness, where it's a high followed by a low, and then a period of normal mood for months in between times. Lithium, I believe, works in about 90% of instances. If you're not using lithium as a preventative agent, the other ones you would look at would be the Epilim, topiramate or Topamax, or one of, again, called the antipsychotic agents, olanzapine, quetiapine, sulpiride, and amisulpiride. These compounds, again, what they're basically doing is focusing on quelling the high side, because that's where the emphasis has got to be. If you want to stop a person having the depressions of bipolar disorder, you can't do that until you prevent the recurrence of the highs. Now, let's look at the treatment of unipolar mania, or the prevention of it in unipolar mania. Lithium only works it's a particular study we did here in St. Patrick's a number of years ago. We found that lithium only works in about 40% of people with this pattern. Carbamazepine, Tegretol, sodium valproate, when added to the lithium, rescues another 20%. And ultimately, the things that work best in this instance are the basic anti-manic agents, such as olanzapine, quetiapine, or haloperidol. Prevention in bipolar II, again, the emphasis has got to be on trying to prevent. The person is down, they've come out of it with the help of an antidepressant, and you're trying to prevent this high happening so that this low doesn't follow. So the aim is to stop the recurring elation, and the depression tends to lessen of its own accord. But frequently, an antidepressant or some type of agent is needed. So the first thing, if somebody has a bipolar II type problem, is to endeavour to phase out the antidepressant if you can. And that's particularly the case if the elation keeps occurring. So you gradually then move in a mood stabilizer such as carbamazepine, oxcarbazine, sodium valproate. So you're trying to sort of have a balance between the amount of upward direction of mood from the antidepressant and trying to cap it then with the stabilizer. There's a lot of tailoring then in the dosages that are required in those instances, because great variation from one person to another. Now, bipolar III, as I said, these are triggered by antidepressants, steroids, ECT, and alcohol. Again, is to try and get the person to see that that's the pattern. In other words, that those agents need to be removed to try and deal with it. So you phase out the antidepressant slowly, or whatever agent is triggering the high. The mood stabilizer are similar to those used in bipolar II. Now, as you can see in Bipolar II, very often the emphasis is on using epilim, tegretol, trileptal, things like that, as stabilizers. In other words, the anticonvulsant stabilizers. Lithium would be less successful in those instances, but not something that one wouldn't try if the other didn't work. So what do we do then in people who have rapid cycling mood disorder? Well, the first thing is to remember that rapid cycling mood disorder, there are many different types of it, but one big group is where it seems to be have its onset. First of all, rapid cycling mood disorder seems to be more common in women. Secondly, it's often found postnatally, midlife hormonal changes, and dramatically then if a woman has her ovaries removed or if the person is put on steroids. And sometimes then another pattern is where a person gets it as they get into their middle years. So in other words, a person may have a recurring depression with lengthy periods of wellness between the depressions, sometimes maybe 10 years in the beginning, their 20s, their 30s it might drop down to 5, then 2, and then it starts cycling in the middle years. Middle years, I suppose, being anything between 50 and 70. Does that mean you live to 140? No. So it's probably a shift either in the hormones, probably the most likely explanation, but it's also possible that there's a change in brain chemistry over the years, because we do know that as people get on in years, that the amount of antidepressant they need as an antidepressant agent is actually much less than they would have needed at an earlier stage in their life. So in terms of the rapid cycling mood disorder, as I say, first is try and phase out the antidepressant, use anticonvulsant mood stabilizers, and they work in about 50% of instances after the antidepressants are phased out. What you will find is with the rapid cycling mood disorder is that it's more difficult to treat, takes a very determined approach to it. It's very important that the person is documenting their mood on a graph in some way on a daily basis. And whereas lithium doesn't sort of work as well as the mood stabilizers, more recent data is showing, well, it's actually just as good. So everyone deserves a chance. If you find that, for example, the person with the rapid cycling mood disorder comes from a history of maybe recurring depressions in earlier life, and then bit by bit the interval between them got less and less, often I think lithium is more effective in those instances. But again, the focus on the rapid cycling mood disorder is you've got to get the highs under control. If you don't do that, you won't get anywhere. The person themselves, though, will only be interested in getting rid of the depressions. And that can be a tough sort of situation where the person is browned off very much so with the recurring depressions. And a lot of the research is now showing that maybe for every 2 or 3 days of a high, the person might have another 30 days of a low. But the secret of getting rid of the low is to stop the high. Now, preventing relapse. The focus has got to be on medication, sure, but the importance of mood monitoring is absolutely vital. We totally underestimate the need for this. Imagine you had got type 1 diabetes and your endocrinologist or general practitioner relied on your blood sugar on the day you came to the clinic. It'd be very hard to control it. Well, mood disorders are not dissimilar. It's been shown from research that when somebody comes along for an outpatient follow-up, how they report their mood has been in the 3 months or 6 months or 1 month since the last visit is largely determined by how they're feeling on the day of the visit and for the 2 days before that. So that's how inaccurate it is. Okay? It's pretty meaningless. And people, they're not going to recall the highs. Absolutely not. Oh, sure, it's great. Next then is, so getting that right, because it's really all about good information. And that's why, again, it's vital to have families involved in giving that feedback. Not any state secrets they're going to be telling us, but just really giving information that can spot what's happening with the moods. Lifestyle changes, getting to bed at a fixed time, getting rid of the laptop, computers, whatever, TV, having quiet time before you go to bed, having a fixed rising time, fixed meal times, because all of those cool down the circadian rhythms. What jet travel does is it disrupts that. What night duty does, it disrupts that. What anything that buzzes you up, too much coffee, steroids, or whatever you're into, that's again what it does. Regular exercise has a calming effect on the brain. It's very important that it's not frenetic exercise, because again, too much exercise can buzz people up. Exercise is an antidepressant, can make people high. If the person has difficulty rising in the morning, use the trick of foot on floor. Try not to think. As soon as your brain wakes up, shift, move. Because once you create momentum and the body gets going, the brain gets going, and it doesn't get stuck in the sort of anxious, complaining thoughts that the brain has, or all the rubbish it's thrown at you first thing in the morning. So that's probably one of the most important things people can do in preventing relapses, and taking small steps. And I don't mean small steps to the toilet. I mean just basically small steps. Doing things, just do the next right thing to get momentum. In other words, and doing the next right thing might be just tying your shoelaces, fixing the corner of the room, whatever it may be. Because everything like that creates momentum. And to get the brain going when a person is depressed, it's just about getting momentum. Just go back to the core thing. It's a slowing of the psychomotor phenomenon. If you get that going, you're on your way. Now, another key thing about preventing relapse is quietening the mind. This is all about quietening the mind. Because medication does it, that's fine. But the point is, what you're trying to do is keep the mind cool so that it isn't on fire with things that go on in life. There are things about understanding you are not your illness, using mindfulness, how to tolerate distress, being aware of your thoughts and your emotions. In other words, when they're there, what inflames them, what is it, who is it, what phone call, what letter, what drink, whatever it is. Just begin to become aware of those things. Validating your emotions. In other words, don't suppress them. Because very often people cope by not looking at what they're feeling. Resisting the urges that fuel emotion. In other words, if talking about politics or watching, he's gone now, Vincent Brown, whatever it is, work out what inflames you, get away from it. Wise mind, in other words, using a mixture of your emotional brain and your intellectual brain. If you're too emotional, do nothing, give yourself time to cool down, and then hopefully you'll have a more balanced approach to it. There are useful little tricks here and there that help people a lot. If you're doing something always one way and it's not working for you, think about doing the opposite. Can't be much worse. And then radical acceptance of illness. That doesn't mean giving in to it. It just means not fighting with it. It's just really accepting that it's there, and how can you chip away at that phenomenon in your life and feel well again. So in terms of preventing relapses, the next thing we look at are dealing with the consequences of the mood problem. In other words, a person who, because of their mood problem or independently of it, have an addictive behaviour with alcohol, street drugs, gambling or sex. Because again, they all are involved with the dopamine system, which drive this psychomotor phenomenon. Okay? Because gambling, sex, any addiction is driven by the dopamine system. Anxiety is a very common co-occurrence, or what's called a comorbid condition, alongside bipolar disorder, even when it's settled. So a person may not have had much anxiety, and they may have been quite calm people before they ever got bipolar disorder. But when the bipolar sort of inflames the brain, frequently, even though the person's mood is stabilized, they can be left with a lot of anxiety afterwards, and they need to address that. So things like panic attacks, social anxiety can be helped by CBT and other interventions. And then finally, well, not finally, but sorting out relationships. So to come to the final piece of the evening, what is it you can do right now? Well, the first thing is to acknowledge the illness. And that's a tough thing, because particularly acknowledging it and its implications is very, very tough. But again, that's something that's got to be faced. Get to know it, know why it's there, how you can modify it, what works for you, what makes things worse, what you've got to stay away from, what you've got to embrace. Medication is a central part of the treatment for most people with bipolar disorder. Many different psychotherapies, including CBT, have been recommended as core treatments. They're secondary treatments. There's no evidence whatsoever that they work as a primary treatment. There's been a lot of research done in this area over the years, and unfortunately, the medication is still the key factor. The next thing is to acknowledge the effect it has on you as a person, but also on relationships. And I think that there are many things you can learn about how to handle those relationships in the context of bipolar disorder, where both you and the family member concerned, or work colleagues or whatever it may be, can get their heads around it. The aware support groups are absolutely fantastic in terms of helping people cope with everyday life. Very often the people who have attended it over the years are absolutely full of information, full of wisdom that they are only too happy to impart and to learn from you, because, you know, time and time again, surveys that have been done in Aware, three key things come out of it. Why do people come and why do they keep coming? One, they needed to be with others who have the same condition. Two, they get help from others. Three, they get great benefit from helping others. And that sort of fellowship aspect of it is invaluable. Now, in terms of prevention, the key thing, as I say, is monitoring mood. And a key aspect of that is how to spot a relapse. You can't always rely on signs and symptoms. Sometimes people have a personal sign that indicates they're going high. As a non-smoker, going back to the cigarettes, the family will often know that that's an indication the person is going high. The person who has no great taste for Tato, and suddenly they have a taste for Tato. Change in internal salt metabolism is often a sign that the person's mood is shifting. Other times it can be an item of clothing a person wears when they're beginning to go high and wouldn't be seen dead in it any other time. But all of those things are sort of not terribly reliable because they're a bit after the fact. The key thing in terms of spotting a relapse is generally, almost always, the person, if they're getting depressed, will be the person who spots it themselves. Then obviously generally spotted way before their family. Not always, but generally. When it's a high, the family will always spot it first. If somebody tells me they can spot their high before their family, I'm not sure. No matter how educated the person is, how much professional qualifications they have in managing these things, if their mood has gone high, a family member will tend to spot it first. If somebody comes into me and I think they're not high and the family member says they're high, I always take their word for it. I think once in 40 years I was wrong in that sense of relying on what a relative said. But the point is, relatives do spot it much more readily because they know the person. They know them intimately, even the way they hold their head, the words they use, what they think about. You know, just we all have our own little pattern, and when we deviate outside that, a family member would spot it a mile off. Why did you say that? You know, so it's just to take that on board. So, what is essential is that you, as aware members came up with this term, appoint a spotter. It's not pointing your spotter as you would as a gun dog, but it's asking a family member whose judgment you trust, who you see regularly, to be allowed to say to you, I think your mood might have gone up a little bit. They need to put it gently, but they need to be encouraged to do it. It's important that you invite the person to do that at a time when your mood is stable, not when you're high, not when you're low, but when your mood is sort of in the normal range. You must give them full permission to take away the car keys, call the doctor, get me into hospital, do whatever you think. Now, you might say, well, am I crazy doing that? Well, you either trust them or trust the illness. You know, that's really what it comes down to. Because people get into all sorts of difficulties if they don't address that issue. And the final point I'm just going to make is about family members. Inevitably, when somebody is depressed, or more particularly when they're high, they'll do or say things that upset people around them. Relatives, being supportive and caring, are sympathetic, understanding and forgiving. They say, don't worry about it. So the problem gets swept aside. That's okay for a one-off episode. But if that happens time and time again, it's like sweeping dirt under the carpet. Everyone looking on in the family, doctor concerned, counsellor, whoever is involved with the person from a therapeutic point of view, can see what's happening here. And then suddenly, one day, the relationship is over. And the person with the illness couldn't see it coming. Everyone else could. So it's important when things settle down in the mood that the person is encouraged to go and talk to that member that they probably know they've upset. And talk frankly and say, look, those things I said to you last week when I was in hospital, can we talk about it? Oh no, forget about it. I don't. It's over and done with. You must encourage them to talk about it, to get out their hurt, to express their upset, because in that way they will learn to let it go. If they keep it to themselves, it just festers inside and then just erupts one day in a breakdown of a relationship that's very hard to put together at that point. Next couple of things are arranging an emergency plan with your treating doctor in terms of what to do. Should it be depression? Should it be elation? Sometimes people who are very knowledgeable about their episodes of highs can be given medication that will keep them going for a few days and bring things under control as long as they're in regular contact. Know the triggers, the alcohol, coffee, tea, lifestyle changes. So, for example, if somebody finds after X amount of coffee, it's hard to get to sleep at night. That person is inviting disaster. They've got to reduce their intake. But how they do that is determined by what they can take in coffee in any day that is not going to cause difficulties. Watch the lifestyle changes, because again, often people who have mood problems, it can be hard to manage sleep, and getting that sorted out, rising at a fixed time, meals at a fixed time, all of that are very, very helpful. Bipolar disorder is something to put your arms around, embrace, and manage it. It is something that is treatable. If a person avoids it, they won't get too far, generally. It's something one has got to face and accept that it's there, but with help and assistance and being open, people can be helped. One of the things that people can do also in terms of getting the monkey off their back is learning to talk to others about it. We did some research here years ago where we compared the outcome for people who had bipolar disorder if they went to a support group, went to an educational program like this that was run over a 4-week period in different combinations, or went to none. So in other words, those that didn't go to either thing went to the support group, went to the lectures, or a combination of both. The people who did best were those who went to a support group. They had fewer relapses. They were more confident in themselves. They had less restrictions in their life. They weren't hiding away from people. And that seems to be the key factor of hiding away, avoidance. Because when a person goes and puts it out there to others, they're also seeing it themselves. If we keep things from others, we also actually keep them from ourselves. We can't actually see them. So that's why it's so important to share with others, because it's free and it works. Thank you.